weekly micro lessons, and 10% discount on paid e-learning courses, all curated to align with local and global guidelines. Join live webinars, over 160 sessions and counting. Earn CPD points on your schedule and download key clinical resources, including templates, research reports, and practice guidelines. Subscribe, get educated, earn CPD points. With the clinical care platform, lifelong learning is just a click away.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
My name is Dr. White. I'm an independent practitioner, and I'm here to share about my experience with CCP. I was introduced into a new and dynamic way of learning. The sessions were interactive and practical. The educators and instructors were easy to approach, easy to ask questions, making the whole experience much more enjoyable. In 2024, I enrolled into the HIV Diploma Preparatory Program, and I am now proud to announce that I have attained the diploma in HIV management. And not only just that, I passed with a distinction with the help of this amazing platform. I'm just here today to express my deep appreciation for the effort and the time that has been invested in preparing these learning sessions from us. You sacrifice time away from your families after long work days to give 1-hour sessions, sometimes 2-hour sessions, and the time that you spend preparing for them as well. You are working towards creating a generation of knowledgeable doctors and specialists, not only in South Africa, but all over the world. The skills that we gain from tuning into your sessions, sometimes attending the live sessions, have also improved patient care and patient outcomes and have been a big contributor. Your work is extraordinary, and I'm here to express our gratitude as your receivers. And I pray that you continue to receive the strength to continue and carry this mission forward.
Well. Good evening, colleagues, and I hope you are well. It's a Tuesday? Yeah. Life can be so hectic sometimes that I kind of like think I almost said to you, is our last webinar for the week and we are heading for the weekend, but I realized, no, the weekend is still a couple of days away. So yeah, I hope you are well and thank you very much for your commitment to professionally develop yourself on an ongoing basis. Just to really appreciate you for always joining, and that keeps me going, that keeps us going as well, to try and see what else we need to do to keep you engaged, to keep you empowered. And yeah, we are grateful to host as well Miss Francina Diane. Hi, Francina. Are you able to hear me? Just say hi to the colleagues. I'm sure they would love to hear your voice.
Good evening, fellow colleagues. Yes, I can hear you, Doctor.
Welcome
I
back
don't need to do
home.
the video, ne?
No,
No.
you'll do it, baby. You can always do it when you after I've introduced you. So there's always the
Thank
story
you.
of the prodigal son. I don't know if yours is the story of the prodigal daughter. Welcome back home. It's been a while. It's been a while.
True, true, true. It's been a very long time.
Yes, thank you. Thank you, colleagues. Colleagues, as you have seen, the diploma preparatory programs are back. Let me find the link which I will share with you so that you can check the page. You saw there Dr. Yolanda sharing her experience, but there's just many more people who appreciate this awesome work. Yeah, let me do my introductory slides just for a couple of minutes, and then so that I can hand over to our dearest speaker for tonight. So yeah, so this is a seminar for audiology and speech, and we are really celebrating this awesome discipline and your contribution to helping people to hear and to speak. And I know personally one of my sons had a stuttering problem, and today you won't even pick it up that at some point he had that, and he was just helped by you guys. So I know sometimes we don't appreciate interdisciplinary approaches and what each discipline brings to the care of our patients. So as much as there's I think this month, Francina, remind me, we are celebrating is it the deafness awareness month or week, but I just wanted to say thumbs up to our audiologist, to our speech therapist, and to those who do both. How is that? So
You
thank you.
did very well.
Yes. So thank you so much. Yeah, so our mission as a platform is to improve patient care, and we want to see that if we make access to these educational events easy for you, can this transform how we deliver care? And so far, so good. We always have testimonials and great stories about people's career being improved, opportunities presenting, and you are so ready for that. So we really, really appreciate you for that. And then the other thing is to say that we continue to celebrate our key milestone. How many of you, are receiving credentials from us? You can see we have now issued over 120,000 CPD credentials to you, especially our members. We really, really want to appreciate you. I know every cent counts, and for you to consider us a valuable institution to invest your resources and your time in, we really feel very, very special. If you are not a member of the platform, you are welcomed. Attend these events, care for your patients better and better, but you will not get CPDs or certificates or anything of that sort, because that requires you to be a member of this platform, which is a paid membership which can start anytime. It will last for 12 months from the date when you decide to join us. It's 3 rands per day, 3 rands per day, which is 1,200 rands for 12 months. Our diploma preparatory programs are up in arms and people are joining since the last couple of weeks. So So please don't lag behind, especially if you are going to be doing child health or HIV diploma. There's some courses you need to complete before the registration by the college opens. Otherwise, you may not get accepted. Otherwise, if you are internal medicine, obstetrics, anesthesiology, or even ophthalmology, well, you can take your time, but please, coaching starts in October, so don't miss your opportunity. We are ready. Yesterday, we had an information session for all these diplomas hosted by me, and now we are going to have one with the host. And tomorrow, expect an invitation for the ophthalmology one. Dr. Taviso will be sharing what the program is going to look like and why you should join. I think it's good. It's just awesome. I'm so excited by this, and the academy is growing. There's 3, 4 courses we are working on, which we'll be adding. But if you need something in dispensing, HIV management, cardiology, nephrology, just visit our website and click on Aqua there, which means Academy for Quality Healthcare. It's our accredited school, and we have big dreams about it. Ooh, this seems very old. Thank you to those who joined us on the 6th, because it's in the past. If you are in KZN, we are coming your way, not virtually, but in person. I can't wait to shake your hands, to give you hugs, because virtually, the virtual hug guy is not working. So please, 25 October, if you are in KZN, try to get closer to Durban, and we are going to put a nice boot camp for you on the FNA. Even if you don't come for the FNA, just come to have lunch with me. I'll be so happy just to host you for that Saturday. So this topic, we as I was discussing with Miss Francina Diane, it's a big topic. So we're gonna do it in 2 parts. Today we're gonna cover a lot of theory around the prevention of hearing loss, and then we're gonna have a follow up where we look at now the actual assessments and how you go about this and stuff. But she will explain exactly what that means, because I'm always better and smarter an hour later. So for now, I'll act as if I don't know much about audiology and deafness, but I can tell you in the next 60 minutes, I'll be the smartest guy in the room. Thanks to Miss Diani for taking us through the journey. She is an experienced speech therapist and audiologist with a demonstrated history of working in the hospital and healthcare industry. She's a skilled language disorders, apraxia, speech therapy, in all these situations. She is a strong healthcare services professional who graduated from VETS, and she recently worked as well as a speech and audiologist at Tembisa Provincial Tertiary Hospital. I know that I didn't ask you if there are updates, Francina. I think as you welcome the colleagues, you can let us know if I have missed something in your profile. Can I hand over to you to share your slides and then also to officially say hi to the colleagues? Thank you.
Okay.
Mm.
Thank you so much, Doctor. I'm still at Tembisa Provincial Tertiary Hospital, yes.
Okay.
I was like, oh my goodness, Doctor took me out. I didn't know. So yeah, and also with audiology, I really enjoy working with pediatric cases.
Yeah.
Yes, I also love working with adults, but if you were to say with a gun on my head, I would say Pete,
It's always, yeah.
So yeah, it's one of the things that I enjoy the most is working with little ones. So today, I was
Don't
discussing
forget
with
to say
Dr.
hi. They want to see you.
Oh yes,
I
sorry,
know
apologies. My manners. My mom would have me for days. My manners. I'll be so killed by my own parents.
just to say hi.
Um, yes, thank you, Doctor. Okay, ladies and gentlemen, colleagues, this is Francina Matseolediani. I'm a speech therapist and an audiologist, as Doctor has alluded. So today, as he also stated, we have the first part, and then we're going to have the second part in the coming, hopefully next week as well. Um, So why I did this was because I'm also asked you, okay, I guess I must do the video. Okay, so
Yay!
Tony can't do that. Tony can't do that. Anyway, so wow, okay, Zoom. Um, why I decided to do these two parts is because I'm a bit concerned, and also I feel like we need to have a different perspective. One of my concerns is that now hearing loss is becoming prevalent a lot. Um, and it's becoming quite a costly service for patients, and it's becoming quite a very debilitating disability for patients. So then I thought, you know what, I'm not gonna just jump into the nice, amazing work only that we do in terms of the testing, the devices we provide, the medical care that we do with the other team members like ENT specialists. I then decided we're going to talk about preventive audiology. And I would like to acknowledge Dr. Khadija Khoza Shangase, because most of the work that I put together was encouraged by the book, and also when she was being ordained, yeah, I think at FEDS last year, it was one of the perspectives that she also tried to make us think about. So today is just for me to challenge all the healthcare professionals, all of us, to really relook at how we manage cases in terms of hearing loss, and how we approach our patients. And the question is, do we really think about hearing when we talk to patients, or is it only when they're complaining about it? You know, so I just want us to have a challenge on that one. Doctor, I'm going to switch off my video, and I'm hoping that everybody understands.
It's
And
okay.
please, and please, you can write the chat if I'm going too fast. Yes. Thank you so much, and welcome everyone. I hope we can all see it.
Yes, you can just put it on. Yes,
Okay.
all is perfect. Thank you.
Yeah. Thank you so much. Just need to move something here. Okay. Yes. Okay. So as it's been said, this is me. So I decided to call these presentations, the coming two ones, this one and the next one, the revolution of audiology. Why I'm saying that is that we have to revolutionize how we observe or how we acknowledge hearing as a country as well. Okay, so this is one of the videos as to why I want us to really think of how we observe audiology, because the aim of doing what we do, and the aim of why we see patients, is because of what you're going to see now. And then I'll explain further. I hope it opens. Okay. Mhm.
Mm.
Ngelanga lami lokuqala ngiqala ukusebenzisa i-cochlear implant.
Francina,
Yes.
Injabulo
you will
phakathi.
have to stop sharing
Ngesizathu
and share
sokuthi
the screen that has the video, because now we still see the slide.
Oh,
Yeah.
okay. So let me do this.
Yeah.
Sorry.
It's the same.
Let me just do this. Okay, so I must go back, unshare and reshare this one.
Yeah, when you reshare, you choose the window that has the video. Yeah.
Okay, cool. Let me stop.
Mm.
I think this is the one. Yes. Just let me know if
we
it's not
we
working.
can see it. You can just take that red dot to the back. Yeah, thanks.
How do I?
There's a
There we
play
go.
button below the red dot. There's a play button there. Just press it.
Yeah. Is it fine?
Yes.
ngelanga lami lokuqala ngiqala ukusebenzisa i-cochlear implant yami kwakunenjabulo phakathi ngesizathu sokuthi ngangithembile ukuthi ngizozwa okukhulu kuzoba nomehluko emva kweminyaka emithathu ngingezwa lutho ngase ngijahe kakhulu ukuthi ngizwe ngesizathu sokuthi bese ngifuna ukulalela ivoice yomntanami ngimuzwe ukuthi ukhuluma kanjani bekunzima for mina yonke le minyaka emva kokuthola i-cochlear implant impilo yami yashintsha kakhulu ngo-2013 November ngikhumbula kahle bekuzobhede umntanami ngathi ngilele ngiyavuka angisezwa lutho ngilale ngi-right yaphuka inhliziyo yami kodwa angiyithathanga ngento yokuthi mhlampe ingase kube into eserious ngabuyela emsebenzini ngabatshela ukuthi angizwa lutho bangibizela amadoktha wabo angi-check-a athi nabo no ayikho into enkinga kulo muntu ngoba ngangicabanga kakhulu ukuthi umsindo endaweni ebengisebenza i-environment ebengikuyona benomsindo kakhulu kwaba nzima kakhulu kumina ngapha ngomntwana ngapha angisezwa lutho ezindaweni ngazama ukuhamba amadoktha ngingalutholi usizo nganikwa amaphilisi amaningi mangingaphazami bengiphuza amaphilisi awu-10 ngelanga because nabo besola bethi une-infection phakathi bagcina benginika i-hearing A1 hearing aid A1 ayizange ngisiza ngalutho ibade boxback maybe ukuthi iyodwa ingadinga mhlampe kube nenye maybe izodongenza ngikwazi ukuba nesawundi engitholayo kodwa azange ngasizakala kuthe ngo-2015 ngoba kwi-April ngasengibona ukuthi ayikho nenye indawo into abangayenza lapho ngingase nje khona lapho ngizosizakala khona omunye amadoktha wakhona audiologist yakhona yaseyicela ukuthi no sicela ukuthumela ebhara uyozama ilapho ebhara ngahlangana khona ne-audiologist abayibiza ngoDeni uDeni wabe sengichazela kabanzi nge-cochlear implant ukuthi yini i-cochlear implant owami umbuzo wokuqala wawufuthi izongisiza yini njengoba ama-hearing aid A2 engangisizanga nakancane umama waye against yona engayifuni ethi kune-operation ake sizame ezinye izinto zezinto ezagcina nazo eziningi zihluleka ngaqhubeka ibhara uDeni wathi ngenhlanhla khona imali ezokhonakala ukuthi ngisizakale ngayo ugovernment uyifakile ngase ngizama ukuthi ngiqhubeke ngihambe khona ngayiqeda i-process yakhona ngase ngitshelwa ngelanga le-surgery yami emva kokuthi ngithole i-cochlear implant impilo yami yashintsha kakhulu ngoba ilapho ngakwazi ukuthi ngizwe ivoice yomntanami engangiyilangazelele kakhulu ukuthi ngikwazi ukuyizwa ngikwazi ukusebenzisa ifoni ngifonele ekhaya ngikwazi kakhulu ukuthi ngilalele umculo engiyithandayo so i-cochlear implant yashintsha kakhulu empilo yami ukuthi ngiqhubeke ngikwazi ukuthi ngifune umsebenzi ekutholeni kwami i-cochlear implant kuvule iminyango eminingi ebeyivalekile ngikwazile ukungena ebhara ngakwazi ukushintsha impilo zabantu umsebenzi engiwuthole ebhara ukuthi ngikwazi ukuthi ngibonise amanye ama-patient ukuthi i-cochlear implant iwusizo kangakanani kumuntu ongezwa iningi lama-patient wethu ayasaba uma ngabe kukhulunywa nge-operation banegama operation or surgery bayasaba kakhulu ukusebenzisa abantu abamnyama esikholelwa nabo into eziningi so abantu abaningi bebesaba indaba yokuhlinzwa njengoba nasekhaya bebesaba ukuthi ngihlinzwe so emva kokuthi abantu abaningi ama-patient eziningi zibone mina ngiyisebenzisa zizijabule kakhulu zikhuthazeke ziqhubeke next process yethu
What's with this claps?
No, that was positive.
Oh, sorry, I didn't do something.
Yeah, stop the
Sorry,
video
sorry.
and then reshare your slides.
Yeah,
Yeah,
I'm
but that
hearing
was
that. Yeah.
inspiring. Thank you for sharing. Colleagues, I'll share the
Thank
link with you
so
as
much.
well.
Sorry.
In Nairobi's informal settlements like
Okay,
Kibera.
got it. You were saying, Dr. Sorry?
No, I was saying thank you for sharing that. It is so inspiring. And one appreciates the, like I said, the awesome work done by the teams. So yeah, thank you so much. And colleagues, I'll share the link on the chat. Those of you who want to relook the video or even use it in your practice so that patients can understand some of these processes. Thanks, Doc. You can continue.
Okay, Doctor, thank you. So as I said, this is the why. In recalling, I'm hoping that everybody will recall the video as I talk, because I'll be referring to it many a times in relation to what we are experiencing in South Africa as audiologists as well. Okay, next one. Sorry, I don't know what's going on now. Okay. So on my content, inverted commas, is we need to re-examine audiology and the way it's been approached across health, education, all of that, and with all of us being healthcare professionals as well. Okay, besides having to talk about what I'm going to talk about, I think we must start understanding the terminology that we use every day when it's in relation to audiology and hearing as well. Audiology, as we say, it is the study of hearing and balance. So it is the science of hearing and balance. Another terminology is hearing is defined as the process through which sound signals are received by the ears and decoded in the brain, allowing for understanding of spoken language. Okay, so this one is important so that you can appreciate the next one. Listening is receiving language through the ears. Listening involves identifying the sounds of speech and processing them into words and sentences. When we listen, we use our ears to receive individual sounds. So those would be like letters and all that. And we use our brain to convert this into messages that mean something to us. Okay. So within the sounds, as we said, hearing will be, we can hear the sounds, we can hear speeches being spoken. Whereas with listening is, I understand what this person is saying because the sound that comes from them into my ears, it got interpreted by my auditory cortex and got returned back to me. So that's what listening is. And also listening requires focus and attention. It is a skill that some people need to work at harder than others. Individuals who struggle with concentration are often poor listeners. Listening as a second language requires even greater focus. So we already know that as a typical growing individual, having to move between languages can also be exhausting for you. Now, let's think of patients that have hearing loss that have to move between. If they don't have a device or anything helping them, they constantly have to concentrate for far too long. They also constantly have to interpret what's been said around them before they even can get the message that's been said. So that is part of listening. So we remember audiology, what it is. Hearing is the sound that travels, whereas listening is understanding what is being said. Okay, so besides all of that, if a patient does not have any or does not have access to those three areas, the audiologist, they don't have access to hearing, they don't have access to listening, it will have an impact on a lot of things in their life. It doesn't just impact them medically, It doesn't just impact their education, it also impacts their socializing, their psychological state, okay? So is far beyond the sounds, but also the pleasures and desires to be part of the communities and society. So it should also be noted that hearing loss is an invisible disability. In relation to having, if you don't have an ear infection, and I'm walking around, like Zweli was saying, he had to wear that device for all of us, if you didn't know him, to show that I actually have hearing loss, because somebody would have asked him, why are you wearing that, you know? Whereas there are some typical patients that they are on their own in their own families and they cannot explain exactly how it feels, you know? So it is an invisible disability. And patients with hearing loss mainly will experience the fear that comes with it because now my world has shut down, especially those that were hearing before and now they're not hearing. They'll experience shock. This one we see it mainly with patients that were not even aware that one of their hearing is having a hearing loss. Apologies with the background. Now, panic also comes from the parents of little ones with hearing loss as well. And with patients, even teenagers, they would also have depression as well. And across all of them, from a child to an elderly, they do experience social isolation because they do talk, but they cannot interpret what's been said, you know? So it's one of the things that as healthcare professionals, we need to remember that one thing, that social isolation does result in fear, it does result in depression, you know, because we all just are communicative people. So we need to also remember why we do what I'm asking of us today to do. And in children, there is language delays, obvious difficulty learning in class. Also, people are experiencing stigmatization. Already when a patient comes to us and we say you have a hearing loss, the first thing we get asked is, am I going to wear a hearing aid? It's going to be in front of people. Now I have to talk. Or they'll be sitting and somebody will be shouting and say, you are an idiot, you are stupid, whereas they don't even understand that I cannot hear, okay? And some of people with hearing loss, they do have a lack of support because it's an invisible disability, so you can't explain it. The best way is you would hope that the next person would understand. And because it's an invisible disability, sorry, I just need to control the situation here in my house. Okay. So because it is can I get a few seconds? Oh, sorry. Apologies for that. So as I was saying, stigmatization that is being experienced by our patients. And because of hearing loss, the saddest thing as an audiologist that I will see is poor employment opportunities. Most of my patients that come, I find that I have to write motivations that are actually teaching on top of everything, you know. The workplaces nowadays do not, some do, but not all of them, do not accommodate people with hearing loss. And I would wish that it happens throughout in all the workplaces that our patients go to, because it's very sad to explain to a employer and saying that this patient can hear speech only at certain things. We need to give a hearing aid so that they can have better hearing. So it's not been supported very well. So they lose their jobs, you know. which is quite sad as well. I apologize for the background. So, in all essence, audiology is a very important science because it doesn't just affect patient medically, it doesn't just affect the patient psychologically, but it also affects them emotionally, their education, and also their employment opportunities. You know, they don't really get to that point where they can go into a place and apply and not having an employer being worried that how am I going to work with you when you can't hear? Okay. But before we manage the hearing loss, one aspect of audiology that needs to be discussed is preventive audiology, which is what we're going to do today. Okay. Why are we doing that? Statistics are saying that 12 million South Africans, this is South Africa, have some form of hearing loss. And 3.6 million, they do require treatments, of whom less than 10% are receiving any treatment. So if I'm pausing because what we are able to access or what we are able to reach to is only 10%. And I will not go into the politics of it because as audiologists, I think why I'm doing this is that we just need other healthcare professionals to also assist us in the advocacy for our patients, okay? Furthermore, between 3 and 6 in every 1,000 babies are born with hearing impairment. The highest numbers are recorded in the public health sector. Unidentified or late identified hearing impairment has significant implications for their speech, cognitive, scholastic of a child. And as I said, it also has a negative consequence for the vocational abilities in the future of a child. So let's just get that sink in. Because this is one of the reasons why we need to advocate for our kids and the adults who are experiencing hearing loss. Okay, so the one thing that why hearing loss needs to be prioritized by all of us is because it is becoming more and more expensive to manage by our governments in managing patients with hearing loss. And if we have preventative measures, we're able to identify all these individuals on time so that we can prevent the hearing loss worsening as well. So according to World Health Organization, it estimates that there's an annual cost of untreated hearing loss in Africa at approximately US dollars 27 billion. Imagine what you can do with that money if you were to manage hearing very well. A figure that reflects the widespread impact of hearing loss on individuals and economies. Because now our patients then become a burden instead of being active members in society because of the poor management that we are doing as healthcare professionals. Okay. I can see the shocked faces. Ask me how I was doing when I was presenting this. So the first approach, besides the one that we're going to do the next session, is the preventive approach. Okay. So according to Dr. Koza Shangase and et al., the prevention of communication disorders to occur, increased efforts are required towards the elimination of the onset and causes of these disorders, as well as promotion, development, maintenance of optimal communication. Okay, so she is just putting it together as to what will be needed to actually improve hearing management. And it can also be affected by hearing function can be affected by a range of factors, including the lifestyle, environmental influences, genetic predisposition, disease burden, where's my English today, and the underlying causes. Hence, we need to work as a team, because it cannot be that maybe a person is born with hearing loss and that's where we stop. There's other causes that are invisible as well, or we didn't know that can actually have an impact on hearing. It can be prevented. Some types of hearing loss can be prevented, and its consequences minimized through preventative measures. Okay. Numerous strategies or many strategies exist for the prevention of hearing impairment across all ages and various contexts as well. Okay, so we're going to talk about the types of preventive audiology measures. Okay, the first one, we call it the primordial preventive measure. So the primordial is what you and I could advocate for our patients, which is having better guidelines being built, having better acts or having better protocols that as their associations, as the government needs to come up with, even ourselves, we need to be involved in as audiologists. Because this is where the crux of the matter is. If there's not enough audiologists, there's not enough money, and then, it affects everything. And then now we're creating burdening situations with our patients. Okay, all health professionals in all levels of service, we really need to start with, let me just go back. I think I missed something. So this is where we need to advocate for prenatal care for conditions known as risk factors for permanent childhood sensory hearing loss, such as rubella, such as HIV, and then plasmosis. Okay. And then postnatally, you also need to advocate for childhood immunizations that are against infections that are risk factors for hearing. One of them is meningitis. The other one is rubella. And then we obviously will have cytomegalovirus, etc. Okay, so we go into the second preventive measure, the primary preventive measure. This is achieved by altering actions or disease-causing exposures, or by growing resistance to the consequence of exposure to the disease. So I'm doing one of them today, which is sharing information on hearing loss. We have what we call the AD initiative that is being done. It's a program that runs on 1,000 days of a child's life. So you can even see it on the that book that kids and mothers take to the clinic. I don't know why I'm forgetting it now all of a sudden. With moms that are coming in before they give birth as well. You talk about how they should look after themselves and how they should eat and all of this, because you never know what will cause a child to have a hearing loss. And preventing HIV clinics, where you talk to the mothers about prenatal healthcare and how to prevent giving or passing on HIV to the kids, because it has been found that HIV/AIDS patients do also experience middle ear pathologies as well. So this will help in preventing audiologists and all of us from missing these cases. And that is, as I said, to sharing of knowledge like I'm doing today. And then we have the secondary one. And this is one that we use the most. We are trying to get it up as audiologists, but it also needs advocacy from all of us. And it is the measurement that we use to identify hearing loss early. So the word being early. So, which is something I'm also going to come back to. Like you saw with Zweli, because he's an adult, he was able to say, I can't hear nothing. And it didn't take too long to actually try and address the hearing loss. Whereas somebody who is in a rural area, early would not be met because the clinics don't talk to the hearing health of a patient. The doctor doesn't know when to talk to the hearing health of a patient, you know. So we are being challenged by World Health Organization to do universal screening. Even our own government is always inquiring about how many kids are being screened by 6 weeks after being born. We had the autotoxicity monitoring. It's not just the MDR TB patients, cancer patients, diabetes medication has an impact. It's been proven. So those are the things that we really need to think about. And I'm hoping that next week I'll show you what I'm talking about when it comes to ototoxicity as well. Okay. So early is important when it comes to secondary preventive. Okay, so these are the types of secondary preventive measures that audiologists try to come into working in. And obviously, we start with newborn hearing screening. There are challenges in that. It's more political as well. There's not enough hands. Even if there's enough hands, patients are not being, it's not being insisted by other healthcare professionals. We randomly have to promote ourselves, which is a concern because it's easy to miss patients when you do that. So advocacy in terms of newborn hearing screening is very, very important. Monitoring ototoxic hearing through screenings, also very important. And then screening noise-induced hearing loss, one of the very important aspects for adults that are working in mines, are working in noise-induced environments. The next one, it's also not been done very well because somehow, again, teachers want the child to say, I can't hear. Moms want the child to say, I can't hear. And some of the kids cannot even describe or have the words to say, Mommy, this is what's happening. And then now you end up as Francina in her office, a teenager coming and saying, my one ear actually does not hear, you know, which could have been identified earlier in grade R if we had insisted on making hearing screenings one of the protocols that have been followed or added into the screening sheets. Then there is community hearing screenings, which are being run by the clinic people, but also it's also based on a patient saying, I can't hear. It is not a priority in a way, in the sense that we do not say, have you had a hearing screening? You know? So patients are also being missed, as we talked about stigmatization, sadness, depression. So they don't know when to say, help me. Furthermore, prevention of sensorineural hearing loss also needs to be addressed with mid-ear pathology assessment and management. And I forgot to put in the statistics on how much of middle ear is affecting our patients. It's really big. And it's a big concern because it's one of the measurements that can be preventative, that can be well managed, that you need a team approach when it comes to it. You know, so whenever an audiologist sees a patient who cannot hear because of middle ear, we always gasp before we help because we know it can be preventative. We know. And use of ear protection in all aspects, especially if you're working in a very noisy induced environment. Okay, so this one is what I'll be doing next week. It's what we talk to this occurs after we have identified a hearing loss in the secondary prevention level. And its role is to lessen the impact of hearing loss in a patient's life long term. So this is where, as Zweli was saying, I went to my doctor, and which is secondary. My doctor couldn't identify what was wrong. Then the doctor then took him to a hearing specialist, which is us. We would like to believe we are specialists, the audiologist, who then identified the problem, which is the secondary preventive. Then from there, it then moved into how do we then help these patients that with the situation or the hearing loss that he's having, which way is the best way to assist him so that he can go back into living his life the way he would like to live it, go back to applying for jobs, just go back to being functional again. So this is tertiary preventive measure. Okay. So tertiary, it is the prevention of severe impact of the condition on the patient's life, that is long life and their quality of life. So this is where now we talk to what the audiologist does to help the patient. Okay, because what we're trying to do is to reduce the impact of hearing loss on the quality of life of the patient. So I'm hoping that it makes sense to all of us. So how you do it is obviously through hearing amplification, and there are those patients that in as much as we provide them with hearing, we still have to train them to listen again. Okay, so in summary, I've tried to make sure that it makes sense to me and to you guys, because having to read up on preventive, for me, it's a new thing, but also it's a beautiful thing that we need to think about. There needs to be policies and guidelines used to prevent hearing loss, which is stated by the primordial prevention. Afterwards, we need to ensure we provide awareness to the communities and prioritize hearing care in our clinics. We will then need to conduct monitoring of hearing and assessments of hearing to ensure we identify the condition early. Early being the very important word. When hearing loss then is identified, the audiologist will then provide amplification in order to prevent the severe impact of hearing loss in the long term and the quality of life of the patient. This is our dream as audiologists. Let's just get it to sink because we need help. Okay, so the new approach, I hope I'm not running out of time. We're almost there. The first stage to preventive approaches that we need to acknowledge is that hearing loss, it is an invisible condition, which needs to be placed as one of the prioritized screenings in the various healthcare professional spaces. Okay. The following can be adopted, obviously. Make sure that in everything you do, there is an audiologist member in it. In the clinics that are running, where we're doing follow-ups, high risk, or we're doing kids being born, 6-week screenings, we need to make sure that there is an audiologist there. As other healthcare professionals, there's this question that we need to change from. It cannot be that we ask a patient, do you have a hearing loss? How is your hearing? No, it's when last did you consult with an audiologist? Questions such as do you have a hearing loss are not effective, as some losses, especially unilateral hearing loss, is invisible to some patients. Themselves are not aware that they have a hearing loss. They will only complain about headaches, fatigue, or ringing in the ear, and poor concentration. But when you test them, that's when they'll start saying, oh, it's making sense now. So we can't be doing it's making sense at an adult age. No, because then now this hearing loss has actually affected their choices of work. It has affected the workplaces that they go to, because you cannot live life being fatigued and it doesn't affect anything, because being fatigued means your concentration is poor, it's affecting your marks at school. So it's a lot. It's a lot that is affected due to the mere fact that hearing loss is invisible. And the elderly population is one that we really need to hone into as well, because this should be also that question: have you had your hearing tested? Why we say that is because most of the elderly are not aware as well of the deteriorating hearing losses that they have. I don't know how many times I've tested elderly people and you tell them you have a hearing loss and they will still say, no, I'm fine. Because with them, I always give an example to say, in the Black culture, what you find is we make so much, our voices are so loud, at home. So because our voices are so loud at home, we are literally accommodating that one person who can't hear. That's why if they're growing up around a big, large family, they don't notice this. So that's why it needs to be a consistent testing every year when they're going to the clinic, because then you will help them to prevent other aspects that are being impacted because of hearing loss, which I'll explain as well in the next presentation. Monitoring an elderly patients by the patient's hearing by the healthcare professionals referring to an audiologist should be one of the prioritized elements. It should not be how is your hearing, it's have you had your hearing tested. Okay, so this is one of the codes that I found. And when I looked at it, I was like, even 20 years of this, I think it's 50 years now, we still are experiencing the same things. Since the solution or amelioration of the problem depends primarily upon the early detection of hearing loss in children, the main responsibility rests upon the pediatrician, apologies, and family physician in those times. But I think we should have the approach of family medicine. Ourselves, as audiologists, and all of us, we should have that approach of family medicine and put hearing as one of the aspects that each and every one of us will look at. And the extent of the problem nationally can be recognized from the reports of many school systems. As I said, a child is born with a hearing loss is not being identified on time. Some kids, their hearing is mild to moderate. So they can hear you talking, but they are missing a lot of sounds. Then you notice that, okay, this child can still go to mainstream, but they are struggling, and the parents are not aware why the child is struggling. We sometimes even get kids struggling and it's been called, no, it's a learning problem. It is, but it's not one that cannot be solved, And because of that, you find mainly these kids struggle in school. Most show that between 2 and 4% of school children have significant hearing loss. So this is 1965. The problems are still the same because the thinking also is the same. We need to think in family medicine concept. It's very important. Okay, so I'm just acknowledging where I got my info. And if you have time, you can actually find Dr. Koza's book for free. I think it's online. And also Tusi and Parkins also, what am I trying to say? Their article is also online. So this will be very amazing, even though now MDR has changed a lot. And the stats as well is like beautifully now that the stats is getting more and more broad. So yeah. So I'm hoping we learned and our thinking is changing. I'll be taking questions, Doctor. Let me just unshare, or should I keep it open?
No, you can unshare. We can unshare,
Yeah.
and we want to give you the DJ's horn.
My goodness, that thing. I
Sorry for
really
playing the
can't get
DJ
it.
horn
I don't
after
get.
discussing hearing loss. I don't know if that is
Mm.
if that is
Hey.
appropriate. Imagine after this presentation, and now I mess up
Yeah.
everyone's hearing.
Mm.
So yeah,
Yeah.
I think
You're
this
gonna
was
buy their hearing aids, all of them. I'm just saying.
no. Thank you so much for this awesome presentation. And there's a lot of advocacy behind it, which is relevant because when we
Yeah.
celebrate these days, these are celebratory. I mean, we celebrate these days, but it's an advocacy time, to remind ourselves
Yeah,
that
it is.
deafness is real, and we don't seem to be taking it serious. I don't know what the issues are. Yeah, colleagues, we're gonna go through your questions.
Yeah.
What I would love to do is just to make sure that you can yeah. So maybe let's start with my question. I had a question as you were speaking. I wrote it down,
Yeah.
but my handwriting is so bad. Now, you spoke about screening recommendations by WHO.
Yeah.
Who is supposed to do the screening, and do we have capacity to do large scale screening for hearing?
Sure. So we have found interesting ways that can help us. And I think one of the ways that has also been acknowledged is actually intro or returning the middle level workers into education, because it's one of, as an audiologist, obviously, as I said, we specialize, we specialists, and we need other aspects of audio, which will be mid-level workers, to assist us in actually screening these kids so that audiologists can really quickly provide the services that they need immediately to prevent all these other aspects that they experience.
Okay.
So because we don't really have a good mid-level worker system, audiologists then end up being the ones doing the screenings. They end up being the ones, after screening, they also have to do the management. But now, then the hands are being tightened. Then we don't have enough hands at all. We already, I think, when I started looking at them doing my researches and doing presentations in like 2019, there were 2,000 and odds of audiologists. Now that the varsities are have separated speech and audiology, I'm hoping there's more. But the issue is now we don't have posts at all.
Do you have
That's why the
unemployed? Do you
pre-modal,
have unemployed audiologists and speech
a lot
therapists?
of them,
Oh.
a lot of them. So because of the pre-modal aspect, guidelines, policies are not in place to support. The varsities created, they opened the system, which was beautiful, but then when they come out of varsity, we are all fighting for the same posts, So it's a bit sad. It's a really sad situation. Yeah, I hope I answered you, Doctor.
Yes, yes. And also, the issue of a lower cadre, I don't have the right term. It's not always a solution, right, in South Africa, because
Yeah.
if you look at the adoption, at least in the pharmacy space, that is where I've seen it
Yeah.
work with the pharmacy assistants, the post basic and the basic pharmacy assistants. Though there's now another one called the pharmacy technician. I don't know where they are in that space, but if you look at us
I didn't even
doctors
know.
and issues of clinical associates, you look at dietitians and
Yeah.
issues of nutritionists, you look at social workers, the social auxiliary, those people are unemployed.
Yes.
The health system has no place for them. I don't know, I'm just thinking my experience with these people who are supposed to be helping has not been very good. And now that there's a lot of unemployed speech therapists, I suspect it's not a good timing to add a lower cut. But I see what you are saying, and maybe we need to look at how you can train me to be able to screen my patients as they come in, and how you can train Sister Mawela, existing cadres. I don't know, so just to respond to some administrative questions that I see in the chat there. Lizette was asking, I'm not yet registered. Will I still qualify for CPD if I register tomorrow? Yeah, Lizette, you have to be timely because our internal process is such that the certificates are released, I know by 10 o'clock or something. They might be out tomorrow morning. We report to the councils. But yes, do register and then drop us an email. And the team is very nice. They are nice people. They'll be able to help you. I saw another administrative process. Sipesitle is talking about DPEC. It's coming. It's in the pipeline. Sipesitle. Just wait patiently there. And then let's head then for some real audiology questions. There we go. Modise says chronic otitis media is very common in the mining sector, probably noise induced. Is this your experience as well, Francina, that there's a lot of maybe hearing loss linked to working in the mining sector, whatever the reason is?
There is.
Yeah.
Yeah, there is. One of the things, and even now, I know one of the professors, yeah, she's a doctor in vets, and also one who's also at UP. They are really trying to push that protocols are being done correctly and compensations are being done correctly for patients who are working in the mines who've experienced hearing loss, because it is there. Noise is another, what is it called now? Noise is really just an unhealthy thing that's happening. I can't find the word, it's gone. That it's a pollution, to tell the truth. So the same way as smells and all of those things are pollution, noise is pollution. And most staff members or employees in the mines need to be monitored better than what's happening now, because hearing loss there is big. It's large. Yeah. In relation to middle ear, obviously the areas themselves, because if you're exposed to dust, that's something that I need to research on, even though I'm not a fan of going back to school yet. I'm not saying I'm not going to do it.
The school is calling.
So the one thing that I am seeing with my case is that most patients that are exposed to dust, constant dust, like especially electrical engineers that we keep shouting at to put back the electricity, the areas where they go, which is under in those holes, those pipes, they have a lot of dust, which affects your nose. When it affects your nose, your sinuses, and some of them, they now end up with ear infections because of that. So it is the same also in the mining industry, that dust has an impact on the nose, and then that also travels because your nose is blocked. It will also create ear infection in reverse somehow. So we're seeing a lot of that. So yeah, that's one of them. Okay.
So Anonymous has a follow-up question. In the military sector, with all the bombs and gunshots, do they need to be wearing something? But that may mean they won't be able to hear the enemy coming, or maybe the technology is smart. How does that work?
Which is fair. I think
Yeah.
Before I even do a presentation next week,
Yeah.
I do have to address this one because we do have types of earmuffs. There's also companies that provide, because remember, even singers
Yeah.
are getting their own custom-made sound
Yeah.
protectors
Yeah.
for when they are singing, so that there's background noise in the audiences is not too noisy for them, so that they can also what is it, detect or listen to themselves as they are singing. So there are ways where you can still bomb and you can hear, but the noise is better, I would believe. But I'll research and make sure that I explain it nicely.
It's a better bomb.
So, oh my gosh, I only got the pun now. So, and then the other way is that when you're working in the military, I know that there is, especially the Pretoria one, they do have an audiology department. I'm not sure about the Cape Town one,
Yeah.
but the military does have audiologists working there.
Okay.
So you can go and make sure that you have your hearing tested. In my recognition of noise is that the bomb noise can actually instantly cause a hearing loss instantly without fail for some patients. So it does need to be monitored better. It does need to be, your ears do need to be protected better as well. Okay.
Full
Let me
fellow
see if
now.
I
Full fellow is asking, Orkana, how do we screen for hearing in the newborn? Like, what exactly are we supposed to be doing? You see now.
thank you for that.
I have the same question. I'm like,
Okay,
ooh, how do we do
so
it?
I guess I must go into my presentation for next week.
Yes.
So audiologists have two equipments that they use for hearing screenings in the wards. So we call the first one auto-acoustic emission. It's an OAE machine that will test your hearing from the outer ear, which I'll also explain next week, to your cochlea.
Okay.
And in there, it actually just sends sounds to your hair cells and then it comes back. So we all have autoacoustic emissions in our ears. It's just now we're testing if the sound that goes in and comes out, is it the same, number one. Then we have the AABR, or automated auditory brainstem response. Now this one goes all the way to the cortex inside. So we use it as a preventative measure, as a site of lesion test as well, because there are kids, especially premature kids, can be born with what we call ANSD. So that is a loss that's why I'm saying it's important to do hearing tests before school. Even you need to send a child for a hearing test, because these kids, sometimes they appear as though they are hearing, and then sometimes they appear as though they can't hear. So it is our role to identify that condition. And then after identifying that condition, you then have to do a hearing test in the booth, which I'll also explain in the coming week, and identify which hearing, how many hearing losses does this child have. Then from there, you can either you can trial hearing aids, but most of them would like them to end up doing cochlear implants to bypass the condition. But there is two types of them. So you can have, that's why we need to do a hearing screen. So one is we do that. We do using the machines, the two of them. Then I know that the Road to Health also has questions. Now, the Road to Health and the implementation of the Road to Health, scary. No,
Two
it's
different
really
things. Yeah.
scary, because sometimes moms come in and they ask mommy, is your child saying a word? As a speech therapist, you have to go deeper into the question, but there are some situations that I've also experienced where a mom is going around with the hearing loss patients, but because the questions sometimes can be vague and they are obviously written in English, And also the nurses are pushing a line. Not all nurses, but they are pushing a line. So they won't really get the right the questions done appropriately. Some of them, not all of them. Hence why I'm saying, irregardless of the road to health, you still need to ask mom, have you taken your child to an audiologist? That's another way of doing it. I hope I answered her
Yeah.
or him. I didn't get the name.
Fulufelo.
Fulufelo.
Yeah. Yeah.
Yes. Okay.
So can you explain the referral process to an audiologist? So maybe from primary health care, how does it work? Do they refer
Okay.
to casualty? Is
So,
there a clinic, or how does it work?
okay. So I'm using Gauteng
Yeah.
as an example.
Mm-hmm.
In Gauteng, to best of my knowledge, because the last time I did clinic was a while back. A mom gives birth. When a mom gives birth, they supposedly supposed to have done a hearing screening then. If not, then is when the mom is coming back for a follow-up, the 6 weeks follow-up, then they have to do a and have to refer to the next level, which can be a regional that might have, if it's a baby, a regional that might have electrophysiology equipment. If that region doesn't have electrophysiology equipment, they then have to take the child to a tertiary hospital with electrophysiology equipment. So electrophysiology is just an objective test that is being used to test for hearing. Or the child, because they don't need to press anything. And sometimes we also still need to test the child to see if they are detecting certain sounds besides even the electrophysiology. So that's the pathway that Gauteng tries to follow. And then hearing test mainly because it is a primary health condition, it needs to start being done at the clinics, most of the clinics. So you'll find that if it's been done in the clinics and they identify the loss, there are some of the situations that they can manage. Then they will also refer to a tertiary hospital or academic hospital for further management. Like Sweli was saying, they tested me, they gave me one hearing, but it wasn't benefiting me. Then he was sent to Bara for further management, which was the cochlear implant. So I hope I make sense. If not, I will bring the info properly next week. Okay.
Awesome. So Natasha says we have to actively ask about hearing at every visit. Can you
Yes.
give us an idea of a few questions? Like how do you screen for hearing, but using questions? Because I guess I can't just say, do you hear properly? I mean, there must be some questions. Like how do you go about asking questions that can give you an idea that there is a challenge?
Okay.
Yeah.
Let me try. Okay, so with kiddies, one of the things you will ask is your child talking? Because the brain is very interesting when it comes to newborns. That's why you cannot, as any human being, any family, healthcare, whoever, you can't say to a mom, no, let's wait, maybe your child will improve. Because at 1, your child should be saying mama or baba, depending on how your child just decides to make fun of you in this life, especially to your mother. That's my own joke. It's my own internal joke. So you then need to make sure that you follow through with the question, is your child speaking? Why are we saying that? Because by the age of 9 months, I don't know if I need to research more on that. By the age of 9 months, children literally stop talking because you cannot speak and then you don't get response back.
Okay.
Doesn't happen like that. So that's one of the questions you
Mm.
can ask is your child speaking?
Mm.
Or are they loud at home?
Mm.
Or are the teachers seeing your child staring at space? It could be other conditions, but it also could be a hearing loss.
Mm.
Does your child miss information when you talk to them?
Mm.
Do you find that you have to repeat
Mm.
yourself
Mm.
when you're talking to your child?
Mm.
Then with adults are you constantly tired? Do you find that you need people to repeat themselves?
Mm.
Are you on any medication that you've been drinking for long? You
Mm.
know?
Mm.
Do you work in an environment that's loud? Let me see, what have I left out?
Eva
Health,
says,
and then obvious. Yeah.
no, I was saying there was one comment by Eva saying, Eva says, I always ask, I'm quoting, does your baby get frightened when the door bangs? So if they don't get frightened, probably they don't hear. I don't know.
Can I challenge her?
No, don't.
It's a good one. I love it. I love it. But
Yeah.
like, I'm gonna use myself
Yeah.
as it's a terrible example because
Okay.
yeah. You know, you can say a child can hear
Yeah.
easily even when they don't, because when you open and close the door, there's wind coming, so they will turn. If it's at night, there will be a light coming from outside, so they will turn. And then
That's from
they
what
can also
age?
see
Is it at what age?
early, like a
Early.
child
Okay.
is sitting. Yeah, a child is sitting. They are used to that door, somebody comes through it. When it opens, they look. And you came from the other room screaming their name. Hey, Pa, Mommy's coming. Who? How's your? And then they look at you, smiling because your face is smiling. Then they react to that face. And then what do we say? No, he can hear. Every time I talk to her, she turns around. No, your shadow spoke to your child. Literally, your shadow speaks. It's the same as me. I'm going to use myself. I am blind as a mouse. So when I was growing up,
You mean blind?
to show you how I'm blind without my glasses, I'm going to say that.
Yeah.
When I was a child, like I just want to give you how your brain can be so smart. It's one of the things I say to moms that if your child can do this now, how amazing would they be if you encourage them to do more things, Because when I was in high school, I also wasn't aware that my eyesight is deteriorating, but I was very clever. I would learn how a person walked, their smell, their voice. Easily. So when somebody calls me and I'm like, I don't know that voice, but I think it's familiar. They'll be walking and I'll be chatting them out until they come near me and I'm like, oh, this is the person. And I'll even compete to say, okay, today, how many people have you identified from a distance? Okay. And then this one will be talking to me. And some people, I then used to just look at how they're walking. And I'm like, oh, I know that walk, and then that will be the walk, And some people are just loud. So okay, this is whose voice. So with kids, it's the same. When it's louder, some of them can hear. When they can't hear at all, they look at the shadow because hearing loss varies.
They
There
figure
are
things
those
out.
that will, yes, they figure things out because the brain is that smart. Hearing loss varies completely. So if it's mild to hear, yes, banging the door, all good and well. But if it's very profound, they're using everything else in the house to give them information. So
Awesome.
very proud, but let's add to that one. Please,
Awesome.
let's add to that
Natasha
question.
says kids are very adaptable. Other senses dominate and compensate in the developing brain. Yeah, and that's being human. You have to be just a bit smarter than them. Woo, Natasha. I wonder how that works out. for us the non-audiologists, because we'll just take, a simple thing like, oh, she's following, it means it's fine.
Yeah,
Matthew
but they
says,
saw your shadow.
startling with a door bang, turning to sound, especially his or her name, is a good screening tool if used at the appropriate age. Yeah, I guess at an older age,
Not
if they
exactly.
know their name. I don't know.
Not
But
exactly.
don't get into
Remember.
it. Don't get into it. I want us to comment on other things because we get stuck. So I want us to, because we have to stop exactly at 8. Just for
Oh,
the
yes,
next
yes,
4 minutes, if we can try and see what else we have here in the chat.
Mhm.
I think Maggie doesn't support the whole idea of a mid-level kind of thing.
Yeah.
They believe it won't work. You don't have to comment on it.
No, no.
Maybe
Yeah.
Abdel is Hamid is asking, earbud user and hearing loss is okay. Is there a relationship between earbuds and hearing loss? I think the earbuds, you mean the ones for cleaning they're not meant for the ears anyway, but the
Yeah, they're
buds.
meant for
I
the
don't
nose.
any relationship between, I don't know, overzealous cleaning of the ear and hearing
Yeah,
loss?
there is. Can
Yeah.
I answer him next week? Because I
Okay.
also need to show you how much of your hearing is affected
Please write it down so
because
that
of
you can
that.
give us the
Don't
science
worry. Okay. And
behind it.
I've made so many promises today.
Yeah.
Right.
This is a very
Uh-huh.
interesting question by Emmanuel, because I know my phone, if I
Mhm.
listen to music at a very loud volume, after, I don't know the timing, it will start to tell me that I've been listening to
Yes.
too much, what.
Mm.
I don't know if it lowers the volume. So he's asked, do you
No,
know?
it just limits.
Yeah, say it again.
It just stops at the safest level. Because
Oh.
if you're hearing noise
Hmm.
at 80 decibels, that is very dangerous. That's
Okay.
very, very dangerous for your hearing. So
Hmm.
it just limits, because now most of the technology now is doing that. It just lets you know that you are going beyond
Hmm.
what we call normal listening sound
Hmm.
level.
Hmm. Hmm.
Yeah, some would be loud, but it's just telling you that don't go beyond this.
Hmm.
You are literally going to affect your hearing if you're going to remain in this here.
Hmm.
And if teenagers,
Hmm.
actually, we can see a dip
Hmm.
that they do listen to noise
Mm.
on our testing. We can see it, and we'll go,
Mm. Mm.
I guess I'm not gonna lose my job because you're gonna lose
It's
your
gonna be a
hearing before I
problem.
even go.
Yeah.
Yes, so we can see. We can
Okay.
see.
Okay.
Yeah,
Um, you spoke because we are discussing prevention, right?
yeah,
So music shows, church and concerts and stuff.
yeah,
Is there anything you want to say about to them? Maybe they are pastors, they are event organizers here. Firstly, is it a contributor to hearing loss? Being I mean, we enjoy, we are so happy.
yeah.
Um, i- i- from a prevention, firstly, is it a big problem? And if it is
It is.
what is the
Mm.
message?
Um, I think somebody once asked me this question. I'm like, yo, how do I, without offending? Sure.
That's why I'm asking it about all events, so that it's
Yes.
not
Because
specific.
I
Yeah.
would wish for what is it called now? We need to have a different way of placing those speakers, to tell the truth.
Mm.
Because they tend to be very close to the congregation, and that's also one of the reasons why it makes it very loud, you know.
Mm. Mm.
It's the same as the concept of placement should also go with how a choir would be placed.
Mm.
There's a different way.
Mm.
Closeness to the speakers is very dangerous because that
Mm.
also goes close to even 80 decibels for those that are listening. So placement of those speakers, very, very important, that it needs to be changed around.
Mm.
Also, the way your speakers are You may need to place certain, like they will have those Hoover speakers where you actually cut the noise in a certain way to actually help with listening as well. So how sound comes into the congregation, you need to actually work on how your speaker look like or how it is to reduce some of the noises. But to tell the truth, the placement of those speakers is very, very important. And also the preachers, we need to find a way to work on how we sound because you're hitting your throat. And I don't mind seeing you, but I'm sure it's not joyful. But yeah.
So there should be
yeah.
a preaching technique, like the singing technique, so that you
Yes.
don't injure the vocal cords.
Because me and the ENT don't mind. We will take out the polyp. I will do the therapy. All good and well.
All right. So Lizette was asking, please be short. At least we slot in 2 questions before 8. Lizette is asking, can using a hearing protection like earplugs cause tinnitus?
No, it
No.
shouldn't. It shouldn't.
Okay.
If you're experiencing tinnitus, your first question is, do I have a hearing loss? Yeah.
And then
That's the first question.
Okay. So, and then do we have screening tools? Like, are there standardized tools which can guide colleagues on how to go about screening? Yeah.
I think I did mention one. I'll just have to share in the coming session. Let me just write it down for us. Oh, gosh, where's my pen? Oh. So yeah, screening tools are there. The ones that you can actually ask patients. Because I know I did talk to it. I just can't remember on what slide. Just put it here. So I'll talk to it as well in the coming session. The tools.
Kimutu says, can it be hereditary, hearing impairment?
Yep, it can. We've had patients where all of the family members besides one having a hearing loss. So there'll be 4 and yeah, it can be. It can be
Sorry,
genetic.
I was disturbed by a question. I was reading another question. Zita says, are we going to address medicine-induced ototoxicity? Who's best suited for that? Is it yourselves or the or ENT or who? Is it yourselves?
Because we also do. We do ototoxicity monitoring ourselves.
Okay, so it's a follow-up topic
Yes.
of interest. Yeah.
Yeah.
Okay, that is fine. Walter was saying, how great is your car stereo? Hey, mine is loud, Walter, I can tell you now. And I grew up in an era where we used to hire a kumbi time and again. Whenever the school said you could wear your home clothes, I can tell you we were not going to use the bus. We were going to hire this kumbi, which is the loudest, and the principal will give us a hiding, but we will be like the happiest people. And even now, I have an old car of mine. It's a Jimmy Suzuki. I tell
those
you,
were the worst.
when I'm in that car, there's the speakers, Dr. Ochan.
You feel alive. You feel alive, I'm telling you. But yeah, I think my take home is please download a sound level meter app and just test it. You will be surprised how much you're listening to.
Yeah, no, mine is
sound
loud.
level. Hey.
But Francina, sometimes we do. Like me, I know my car is loud and I have no plans. I have no plans to reduce it. I can tell you now. Even
just
if I
open the window.
And if I measure it and it's very high, I'll be so happy. I'll be even saying, no one has the loudest car.
I think audiologists, we must check if noise is not addictive now. I think it's one of the questions.
And I think my middle ear bones have adjusted. They already know what to do. You know, they know, right? For the past 40 years, I've been enjoying music.
We'll test. We just come, I test you, and I show you what is it doing. That's all I can tell you right now.
No, but you know what I'm trying to say. I'm just saying, Shem,
Yes, true,
it's
true.
like if you're
Yeah.
diabetic, there's a day for ice cream, isn't it? It's not like you can't eat ice
Yes.
cream, you know. So if it, for music, there's my day where I just need the volume to
True.
to distress.
But I think noise is addictive. I must actually get that researched,
No, for
really, to
sure.
tell the
For
truth.
sure. For sure. Cochlear transplant, Gauteng, that thing, the video said 250,000. Do you know what it is, the price in the private sector for a cochlear implant? Is the last question I think we can respond to. Hi, Francina. You are muted. I don't know why. I can see you are muted.
My goodness. Okay, sorry.
Yeah.
It ranges from, I think it's 270
Mhm.
to 300,000.
You.
Yeah, it's
Okay.
actually installment of a house. So, and then in government, because we're using the tender process, so the contract process, they've really tried to push it down to 250, but that's how expensive they are. Hence, I had to talk about how much are governments paying just for hearing. And some of these hearing losses can be prevented, to tell the truth. Yeah.
Awesome. Colleagues, that's it for tonight. I hope you have enjoyed this webinar. Francina Diane, re a leboga. Thank you so much. I know what it takes to prepare for any 1 hour talk. It takes you a lot of time, so we don't want to take it for granted, but to just appreciate you. Colleagues as well, if it was me and Francina, I don't know what the talk would look like. So we really appreciate you for joining and for all the questions you have posted. In the chat, I've been sharing a couple of links. There is a WhatsApp link if you want to get our updates on time. The diploma preparatory programs are open for registration. And if you are not a member of the platform, there's a link there. Join, check it out. Join us on this incredible journey. You'll have a peace of mind. You'll enjoy education like never before. On that note, may I wish you a restful night with your families till we meet again. Night, night. Bye.
Thank you for listening. Bye.
Bye.
In today's fast paced world, keeping up with the latest medical knowledge can be a challenge, especially for healthcare workers striving to provide the best care possible. Introducing the Clinical Care Platform, a proudly South African, wholly owned online subscription edutech company built for healthcare professionals. Our mission is simple: to improve patient care by increasing access to high quality, evidence-based educational resources, anywhere, anytime. With our membership subscription, you gain unlimited access to a growing library of over 155 CPD accredited courses, weekly micro lessons, and 10% discount on paid e-learning courses, all curated to align with local and global guidelines. Join live webinars, over 160 sessions and counting, earn CPD points on your schedule, and download key clinical resources, including templates, research reports, and practice guidelines. Subscribe, get educated, earn CPD points. With the Clinical Care Platform, lifelong learning is just a click away.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson and more. Visit www.clinicalcareplatform.com to sign up.
My name is Dr. White. I'm an independent practitioner, and I'm here to share about my experience with CCP. I was introduced into a new and dynamic way of learning. The sessions were interactive and practical. The educators and instructors were easy to approach, easy to ask questions, making the whole experience much more enjoyable. In 2024, I enrolled into the HIV Diploma Preparatory Program, and I am now proud to announce that I have attained the diploma in HIV management. And not only just that, I passed with a distinction with the help of this amazing platform. I'm just here today to express my deep appreciation for the effort and the time that has been invested in preparing these learning sessions from us. You sacrifice time away from your families after long work days to give 1-hour sessions, sometimes 2-hour sessions, and the time that you spend preparing for them as well. You are working towards creating a generation of knowledgeable doctors and specialists, not only in South Africa, but all over the world. The skills that we gain from tuning into your sessions, sometimes attending the live sessions, have also improved patient care and patient outcomes and have been a big contributor. Your work is extraordinary, and I'm here to express our gratitude as your receivers. And I pray that you continue to receive the strength to continue and carry this mission forward.